Recognize, let's see, Mr. Webster.
Thank you, Madam Chair. Thank you all for appearing. This is a great work you're doing, and we really appreciate it. Mr. Meek, you talked about, I don't know your exact words, but you talked about the fact that technology was ahead of the VA's practice, in a sense, and that you get these technological advances that are not a part of the normal VA treatment. I would assume, I don't know this is true, but I make the assumption that advances in technology usually cost more, and that if it does more, it probably costs more. But my question would be, how do we balance that? How do we mold together availability and advancement so that, I mean, you could have this scenario where you make an advancement, and if you spend all your money making advancements, then you could come up with something that helped a veteran 10 times better than current practice. However, you could only afford 1 out of 10, where under the old technology, you could afford 10 out of 10. Is there a balance there? Do you see what we might be able to do to certainly want to make advancements, but we also want to be able to pay for it?
Sure. So I think to go back to the earlier question about, excuse me, whether the DARPA should be a model to transfer over to the VA, I think it should be. You know, we put the most advanced technology we can in our warfighters, but once it's done meeting DARPA specs for the battlefield, that's it. The funding stops. There's nothing to I'll say, commercialize that for the private sector back at home. And so you look at a lot of these devices. I mentioned how the average cost that we fund is $100,000, with a couple of them almost $200,000. Think about the original cell phone. It was the size of a small suitcase, you know, and cost $1,000. Well, today it's the size of a calculator, and it fits in your pocket, and it's a supercomputer. So having that continued research and development on a specific device, whatever it may be, for advancement, you know, where that funding comes from, there are certain, I think, separate pools that we could look at. But you have to keep that funding going, because over time it will bring costs down. You know, a lot of these devices are so advanced that yes, they cost a lot right now, but 10, 20 years from now, you know, we know some of the work that Dr. Major's doing, you know, they're hardwiring some of these devices into individuals' brains. You know, I've seen virtual reality where somebody lost their arm in Vietnam, and through virtual reality actually felt himself opening a doorknob, and he cried because it was the first time he touched something in 25 years. So this funding has to be found somewhere, because in time, not only will it reduce the cost of those devices, it's going to reduce cost of medical and VA care for those patients.
Well, I saw a live presentation of the type technology you showed in your video, and I was just totally astounded. Someone could actually go from a sitting position and rise with no help at all, not even necessarily using their arms. They could just get up. So I'd want everybody to have that. It's just the idea of making it available is an expensive, and sometimes that would come at the expense of any more technological advances. I had another question. Well, that was Mr. Wordin. You mentioned, this doesn't have anything to do with that particular issue. It has to do with self-directed care, mental health care, which I have, you said something about that. I don't know exactly what you said, but it struck a note that that's what you were talking about. In that the person would help in the direction of what they would be choosing for their mental health care. I have seen that work in the private sector. Do you think that ought to be more uniformly applied in the VA?
I don't know if I'd use the word uniformly, but I think it needs to be available, because every veteran that suffers from PTSD is different. If you've seen one veteran with PTSD, you've seen one veteran with PTSD. And I think what they find as their support system individually is the most important path. And the great thing about the HeroTrack device is it gives them feedback individually, so then they can make decisions for themselves based on how their quality of life is that they want or that they have right now. And so if you go to the VA and you see your mental health clinician and he goes, well, how are you sleeping? Oh, I'm not sleeping so good. Well, we're going to give you some Ambien. Well, how do you know whether that actually does any good for you? Well, with the device, you're able to monitor and look at sleep patterns, look at PTSD episodes during sleep, and be able to decide whether or not that's something, because every prescription drug that you take has a side effect or it has some kind of addictive quality, and that affects your quality of life as well. I mean, we have veterans in our program that literally have suitcases full of prescription drugs that the VA sends them on a regular basis, and then when they get into our program, they get off of those prescription drugs, and yet the VA continues to send them the prescription drugs. And when you talk about costs for technology, technology is way cheaper than prescription drugs.
Yes, that's not shocking. And that's awesome. Thank you all for appearing, every one of you. It's been very encouraging, each of you and your work. Yield back.